All right, hello everyone. My name is Tiara Brooks, and here at School-Based Health Alliance, we would like to thank everyone for attending today's webinar titled, Addressing Social Determinants of Health in the Adolescent Medical Home. Today's presentation will review the literature of social needs, connecting patients to resources, and utilizing multidisciplinary team members and proposed framework for addressing social work determinants in the clinical setting. But before we begin, we have a few housekeeping reminders. First, please help us with our attendance count. If you are viewing as a group, please go to the chat window in the question box and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the question box located in your GoToWebinar control window. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete the evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations to meet your needs. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students already spend the majority of their time in school. When health and education come together, great things happen. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archived webinars for topics such as the ones you are viewing on your screen. Get ready for our 2016 National School-Based Healthcare Convention in Raleigh that will be held in a few weeks in Arlington, Virginia, June 26th through 29th. We hope you will join us for another year of innovative workshops and engaging speakers. Please visit our website at sbhforall.org/convention to register and for more information. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. Now, I would like to introduce our presenter today, Dr. Tamara Baer. Dr. Baer serves in joint roles as faculty in the Division of Adolescent and Young Adult Medicine at Boston Children's Hospital and Harvard Medical School and an associate at McKinsey & Company. She is passionate about improving healthcare delivery to underserved populations and is gaining experience in and knowledge of business strategy, health systems, and organizations, while also continuing to advance her clinical skills in the care of adolescent patients. She serves as a member of Board of Advisors and a member of the Food Security Task Force for the Greater Boston Food Bank and is Institutional Review Board member at Fenway Health in Boston. One of her most recent publications, Addressing Social Determinants of Health in Adolescent Medical Home, inspired our new 6-blog series entitled Coordinating Care Around the Social Determinants of Health. The blog series began in May with a summary of the framework described in the article written by Baer and colleagues, and will continue once a month with stories and resources from clinicians that demonstrate the impact of safety health sensors using a social determinants lens when providing coordination of care for adolescents. We ask that you please visit our website to read the blog on sbhforall.org. Thank you, everyone. I will now turn it over to our presenter, Dr. Tamara Baer.
Hi, everybody. Thank you so much for having me as a speaker. I really want to thank the School-Based Health Alliance. And certainly, I'm a very strong believer in school-based health clinics, so I'm very excited to speak to all of you today. Sorry, Tiara, I think I'm having trouble advancing. I think you need to pass it to me again.
Click the slide, just click it, and it should work.
Here we go. Sorry, everybody. Okay. So the objectives of this talk today are to understand how social and environmental factors shape adolescent health behaviors and health outcomes, to learn about screening tools to detect social needs, and to think about a framework to screen for and refer social needs in a school-based health center. Okay, let's start with a quick case. And this type of scenario may sound familiar to many of you. So Jenna is a 15-year-old adolescent female who presents to her school-based health center nurse with headaches. This is the third time in 2 weeks that she has come in during class. And some of the background on Jenna, she's having problems with behavioral outbursts and physical altercations at school that have led to 2 emergency department visits. She's failing the 9th grade. She was on an IEP, or an individual education plan in middle school for a learning disorder in reading, but she just transferred school districts for high school and has not had an evaluation done yet. Her mother is concerned that Jenna may drop out of school because Jenna's boyfriend didn't complete high school. And what's going on at home? So Jenna lives with her mother and 3 siblings, the youngest of whom was born prematurely and diagnosed with both cerebral palsy and global developmental delay. Jenna's mother is unemployed, and Jenna has considered dropping out of high school to work to help her family financially. Jenna worries that her younger siblings are hungry, and she has been skipping dinner so that they can have more food to eat. And when the nurse asked Jenna about her review of symptoms, Jenna reports that she's having daily headaches every day during school and on weekends, and she's tired and irritable. So to some of you out there, this may sound familiar. Certainly in my practice, this is a very common scenario. I've seen so many of my patients come in with ongoing stomach aches, headaches, sort of lots of chronic symptoms that when providers don't necessarily know what to look for in terms of root cause of their illness, they often end up on a lot of medication that sometimes doesn't fix what the problem is. So for example, especially for this headache case, I learned to ask about food insecurity and hunger and patterns of eating in my patients who come in with headaches, because once you start asking the questions, you realize that a lot of patients don't have reliable access to food at home, and on top of that, especially being teenagers, most of them don't eat breakfast. They sleep to like the last possible minute when to make it to school on time or late, and then many teens don't like accessing free breakfast at school because of the stigma. So a lot of times they come in and don't eat anything for the first time until the middle of the day, and for some of my patients, they don't actually eat anything until it's a bag of chips, in the afternoon. So I've definitely learned in my clinical practice to really start thinking about what else is going on to drive some of these sort of chronic symptoms that are oftentimes a manifestation of stress, but also a reflection of other sort of social problems going on at home. I apologize for the delay on the slides. Okay, so when we talk about social determinants of health, what do we mean? So the WHO, sorry, this is not advancing on time, go back one. So the WHO defines social determinants of health as social, economic, and environmental conditions that affect individual and population health. So if this does go back a slide, which I'm trying to get it to do, basically some examples of these include poor housing conditions, inadequate nutrition, and limited access to health care, among many others. Here we go. So these are all conditions, as you'll see on the right side of the slide, that are associated with poor health outcomes, and that's been shown in the literature, and as a result, higher healthcare costs. And so one other term that you'll hear me use during this presentation is health-related social problems, which is another term for social determinants of health. And so you use them interchangeably. So there's been an increasing recognition that social determinants are important and critical to address in the healthcare setting. I think particularly over the past 5 years, and even more over the past year, there have been some exciting improvements, or not improvements, but advancements in terms of how much attention this is getting. So a Healthy People 2020 goal is to create social and physical environments that promote good health for all. And Healthy People 2020, which is a government program, has emphasized cross-sector collaboration to create effective programs that improve health for Americans. So I mean, school-based health clinics to me are a perfect example of the type of setting that Healthy People 2020 is aiming for. The American Academy of Pediatrics has recently moved from recommending that pediatricians understand social risks on child outcomes to actually providing guidance that pediatricians should routinely screen for food insecurity during child care visits. So this recommendation was made in October of 2015, and this was due to the number of studies that have come out that have demonstrated that food insecurity is associated with poor child health and developmental outcomes. And there's also now a validated screening tool which is quick and easy to use in the clinical setting. So because of that, for those of you who are familiar with Bright Futures, which is the American Academy of Pediatrics guidebook for pediatricians on what to do at Welsh child care visits throughout ages 0 to 18, and even past that, food insecurity screening is now recommended as a routine screen. And then most recently, Centers for Medicaid and Medicare Services announced $157 million in pilot program funding in January 2016 for program models that address social determinants. So this is, again, a very exciting advancement because organizations were asked to submit pilot grants very recently, and it'll be interesting to see what comes out of this, but it really shows that there is much more attention being paid, both on the provider side, but also on the payer side. And for those of you familiar with payment models in healthcare, the shift towards accountable care and population health, I've seen interest in this both on the private payer side and the public payer side. So why are social determinants of health particularly important for adolescents? So I think there are 3 main reasons. One, adolescents are building the groundwork for their future adult health. So as most of you know, there's so many factors that go into shaping the adolescent experience, including genetic predisposition, early childhood experiences, the adolescent's social context, all of the physical, sexual, psychosocial, and cognitive changes that are so rapid during the physiological development in adolescence, the community context in which they're growing up, and then their own risk behaviors. And so these risk behaviors and risks in general, can be a huge driver for how the adolescent makes it out of the teen years into the adult years and sort of what their future pattern of adult health is. So most of you know adolescent morbidity and mortality are driven primarily by unintentional injuries and violence, alcohol and drug use, and sexual behaviors that lead to disease transmission and unintended pregnancy. But on top of that, I think we as providers and supporters of adolescents need to anticipate sort of other risks that especially can compound those that we just mentioned, and definitely impact their ultimate success in adulthood. In addition, adolescents are a very high-risk population in general, and they experience significant health disparities. So 20% of adolescents live below 100% of the federal poverty level. Adolescents and young adults are less likely to have health insurance than any other age group, and this is true even since Obamacare. And poor and underinsured adolescents utilize fewer preventive health and reproductive health services than any other age group. Particularly, as we just talked about, what a risky group they are in terms of their health behaviors. I think as much as we can do to support them as a population, this is important. I think for me as an adolescent medicine provider, I realize that adolescents, as a third element of this, are just not a popular group. So, pediatricians usually don't go into pediatrics thinking, oh, I just love to take care of teens. It's usually like the babies and younger kids that really get people hooked on pediatrics. And certainly for adult providers, usually it's not the young adults and teens that they're also looking to treat. So adolescents fall as this sort of in-between age group that definitely falls between the cracks of pediatric and adult medicine. And in addition, we just don't get trained as physicians well on how to treat adolescents in best practice. So there have been so many studies that have shown that most pediatricians don't feel comfortable counseling about adult topics. They don't kick the parents out of the room to do confidential histories, and they've, some very infrequently even ask about sexual health behaviors and other sort of risky behaviors, and in part because they don't want to get into it. There's also limited time, and they also don't really know how to counsel or feel comfortable counseling. So I think this is where school-based health centers are particularly important, because adolescents are receiving confidential care in a setting with caretakers who are all truly dedicated to youth in the adolescent age range. So on top of all this, the research has shown that health-related social problems among adolescents are common. So this study featured on the slide was done in my clinic at Boston Children's Hospital among 401 primary care patients with a Boston zip code. So this is definitely a diverse group. I would say probably 60%, maybe a little bit more, were on Mass Health or Medicaid. The rest were private insurance. And when we asked adolescents through a web-based screening tool, self-screening tool, about a number of health-related social problems, we found that adolescents are willing to report them, and they are common. So among this population, 76% of teens in our clinic had at least one, 47% had two, and 27% had more than three. And the main health-related social problems were problems with healthcare access, housing, and food insecurity. So I think one unique aspect about this study is that it's one of the only studies out there that actually directly asks teens what their problems are. Most of the studies into the pediatric literature have been done using parents or caregivers reporting on behalf of their children. And most of the studies are done in kids under the age of 3, and some in the school-age population. So I think this study is nice to know, because it shows that adolescents are aware of their problems and they can report them. And this is especially important in school-based settings where adolescents are seen without the parents with them. So despite the fact that there are a number of health-related social problems among children and adolescents, they're limiting screening or referrals for resources. And this has been shown across a number of studies, both in the pediatric age range as well as adolescent age range. We'll talk about some reasons for this in a minute. So what are the barriers for addressing social determinants in the clinical setting? So first, there are limitations to provider availability to triage these needs. Medical providers don't usually feel comfortable screening for social determinants because they were not trained to do so. The typical social history taught in medical school, you might learn about asking about the type of education you received, the job, marriage, or sort of your current relationship status, for adult populations, obviously. And for kids, favorite activities, siblings, those types of things. But I certainly was never trained in medical school to ask about food, and hunger, types of housing people are living in, and whether their housing is actually having problems both structurally or, paying utility bills. Income insecurity, we were not taught to ask. I think there's been some programs in medical schools across the country that are new, that are trying to start teaching subsets of med students about these topics, but traditionally it hasn't been taught. So I think, one, people don't know how to screen. I think there's also, I think providers don't necessarily know that there is this link between how much these social determinants really drive healthcare outcomes. And in addition, there's time constraints. So especially in the era of increasing numbers of quality measures that providers have to ask, or sort of checking more boxes for things that they're reporting back to insurance companies, Medicare program, Medicaid programs. People aren't looking for more questions to ask, because that's another limitation. In addition, I think physicians in particular are hesitant to screen because oftentimes they don't know what to do when they detect a problem. And in medicine, we're so trained to learn. You want to diagnose something and then fix it. And a lot of these problems aren't immediate fixes. So I think especially if doctors don't feel like they have a solution, it may prevent them from actually wanting to ask the question. Some clinic settings have a really strong presence of other professionals around, like social workers or nurses or other clinical staff who can help out. But as you know, many have very limited resources, and providers are there on their own. And providers may not know what resources are available in the community, and they also just may feel like these problems aren't fixable. So what are some solutions to address social determinants, given the barriers that we just talked about? So this slide has the framework that we were alluding to earlier. So first, improving triage, meaning detecting these problems with screening tools. Second is providing information on resources to patients And third is expanding clinical staff to connect patients with resources. So in terms of screening tools, there are provider screening tools out there and also patient self-screening tools, mostly under development. We'll talk about one that is the NICE model. So for adolescents in particular, the HEADS assessment, which is the first bullet on there, is the classic teaching around a social history. And this is really a psychosocial review of symptoms. So probably all pediatric residents are taught to ask about home, education, activities, drugs, sexuality, and suicide and depression. And while this is not meant in its origins to be tailored to thinking about social determinants and sort of basic needs and root cause of illness, certainly if people are already using this as a screening tool or sort of something that's in their regular practice, I think it's just knowing how to tailor these questions to get it, to give a different spin. So for example, I think most people would ask, who do you live with? Do you get along with your family at home? But not take the next step of what type of housing. Is it public housing? Is it an apartment? Is it a private home that you own? Are there any problems with your housing that's driving any poor health, it's sort of affecting your health? Are you able to pay utility bills? For education, I think we're taught to classically ask, what grade are you in? How are you doing in school? What's your favorite subject? And stop there. But really, are you getting the help you need to be able to achieve? Are there any barriers that you foresee in your education that you need help with? Any learning disorders? How else can you, what other help do you need? And so on. So the second screen up there is the iHelp screen. So this screen was developed by an organization called Medical Legal Partnership, which is now actually based out of Washington, D.C. And this tool was developed as a basic needs screen, and we'll look at this more closely on the next slide. The RAPS-PH, which stands for the Rapid Assessment for Adolescent Preventive Services, is an online screening tool developed by the University of Michigan. And I think primarily it was developed for research purposes, although I think it's being used in organizations. I actually haven't personally used this yet. You have to pay for the tool. You can download a sample on their website, and it's a 21-item screen that does address some social determinants. So it's just something to be aware of that's out there, and certainly I'm not as familiar with this from the clinical side. And then finally, there are some examples of patient self-screening tools. So Health Steps is one of them, and this is what we had used for the research study that I talked about a little bit ago, and we'll talk about another one coming up. But it was developed at Boston Children's, which with the intent of being a social determinant screening tool that not only identifies health-related social problems, but also links patients to local resources through their zip code. And the way that this was implemented in the research study is that the patients were given an iPad, and they were able to walk through a series of questions around food and housing and income security and substance use and a variety of other domains. And at the end, based on where they indicated they wanted help, it would spit out a number of resources local to their zip code. So the nice thing is it really tailors it to where people are geographically. And the Department of Public Health in Boston has now partnered with Boston Children's, and they're rolling this out across the state. And I've heard from community organizations that it's actually a great tool for them to use with clients, because clients can use it on their own, but also you can pull this up together with your either community advocate or your provider and do this in the room. So anyone can sort of play with this online. Right now it's only available for Massachusetts. But I think the point of the self-screening tools are, in other research studies, they've used much more simple screens. So I think in terms of thinking about how do we actually do this in a school-based setting with potentially, there's not a budget to sort of develop a fancy online tool. Certainly if we think about what are the questions that may most apply to our student population, and there could be even a piece of paper sitting on the desk of the nurse or the doctor in the clinic that teens can fill out either when they check in, or be something around to say, having problems with X, Y, or Z, talk to us about it, because we do have resources to help. So this is the iHelp screen. So this is not a validated screen. So while I think it hits on the main areas of basic needs, certainly in terms of if people were concerned about timing or the relevance of some of these questions to specific populations in your school-based health clinic, you could pull and sort of focus on a few of these. So I think the nice part about it is that it's much shorter than the 21-question screen. It does sort of hit the main areas. So this gives some examples of what each letter represents. So for income, does your family ever have trouble making ends meet? For food, within the past 12 months, have you worried food would run out? The housing, have you lived in more than 2 addresses in the past year, or do you think you are at risk for becoming homeless? These are actually validated questions from a research study that give a good indication of risk of homelessness. Is your housing causing health problems? We talked about the utilities question earlier. And education, do you get special services in school? And that could always be a follow-up of, if so, do you feel like that's enough? Or if not, is this something that you should be getting? Legal status, literacy, and then personal safety. If you had to pick one question out of all of them that could be sort of the go-to, at least starter question to open up the conversation, which would it be? So I think food insecurity screening can be a good starting point. And I actually published research last fall to show that food insecurity screening actually can be a window into other social problems and sort of be that Pandora's box, where if someone says they're not food insecure, it's a pretty good chance that they don't, not 100%, but there's a decent chance they don't have other social problems going on. But kids who screen for food insecurity positively have a much higher odds of having a number of other social problems and some of the domains we've mentioned previously. So the screen that I mentioned that is on the screen is by Aaron Hager and colleagues. So basically, these 2 questions have come out of the U.S. Department of Agriculture's food security screening tool, which is an 18-item tool that they use as an annual sort of food security screening, nationally. And Hager and colleagues said, well, what are the 2 go-to questions that indicate food insecurity and are pretty reliable, because asking 18 questions in the clinic is just not practical. So they validated these questions among 30,000 families with children under the age of 3. So again, it was caretakers reporting on behalf of their children, and they found that answering positively to one or both of these is reliable to indicate food insecurity. So we worried whether our food would run out before we got money to buy more, and the food we bought just didn't last, and we didn't have money to get more. So in my study, we looked at teens who screened positively for food insecurity using these 2 questions, and found that teens who are food insecure had significantly increased odds of having other health-related social problems. So this next slide is a figure demonstrating how food security level correlates with other social determinants. So the USDA measures food security on a continuum, for those of you who aren't familiar. So essentially, high and marginal food security means food secure, so no problems with reliable or consistent access to nutritious food. Low and very low are the categories that indicate food insecurity. So each bar that you see on the x-axis represents a different social problem, including problems with healthcare access, housing, substance use, education, and income security. And so as food insecurity increased, meaning going from left to right on the slide, the presence of other social problems increased as well. And these were statistically significant. And then we looked at each of these in an odds ratio. Being food insecure meant having 2 to 4 times greater odds of having an additional social problem in each of these domains. So we concluded that the food insecurity tool, food insecurity, can be a nice initial screen to detect patients who have other social problems. And one more word about food insecurity, I think particularly in teenagers. I think sometimes the face of hunger, people think of little kids, and certainly a critically important group as well. But keep in mind that teenagers are going through rapid physiological changes. They're growing, their bodies are changing. Like, they are a group that really, really needs access to food. I think we forget about them a lot of the time. So, I think one thing is that you can do something about food insecurity. I mean, you can give people food, which is, or help connect them, which is nice. But I think especially for teens, it can be a good sort of window into further conversation. So the next part of the framework is to provide information on available resources. So we talked about how one reason that providers do not screen is that they have limited knowledge about resources. And so one example of resource information delivery, there is a website tool that has a collection of parent handouts called the Children's Advocacy Project of America, or CAP for Kids. So this was rolled out in Philadelphia, and now it's spread to a number of cities in the U.S. And again, you can log on to their website and see the types of handouts that they have addressing a number of different social problems. So I think this is a great example of something that could be developed in every city or even in smaller communities. But I think, again, as a sort of lower resource tool, I mean, I think schools could start putting together at least binders with information on community resources, or think about using the school website and have a placeholder on there for some local community resources for students and families. And then finally, clinics can expand clinical staff through volunteers and also professionals. So in the volunteer category, student volunteers are one group, and we'll talk about a program that utilizes student volunteers in a minute. And then user parent advocates. So when I think about volunteers in the school setting, I am aware, especially for students, that a lot of what we're talking about can be stigmatizing. And so, the idea of having other students serve as volunteers to peers who have social problems, well, I think it's a great idea. I mean, I think in practicality, I'd be worried that kids wouldn't want to open up to other peers around these types of issues. But I do think the parent advocate angle could be an interesting area to explore. So, parents who have had experience and success accessing resources for their own families, can be great resources for other parents. And in the clinical setting, a lot of clinics are using patient navigators. So a similar idea, it's either sort of community members with some extra training or former patients who have had success sort of navigating their own healthcare and then can help others. On the professional side, there are paraprofessionals, which can be resource specialists or outreach workers, and then professionals, meaning social workers, case managers, and lawyers. Sorry, trying to advance the slide.
Okay, I'm going to try to...
Thank you. Thank you. So one example of the volunteer model is health leads. And some of you may be familiar with health leads. It started at Boston Medical Center in 1996, and now there are over 21 help desks nationally, and they use over 800 college volunteers across 12 universities. So the idea of health leads is for college student volunteers to be trained to assist patients with meeting basic needs, and they sit at help desks in urban clinics. I had the opportunity to work directly with health leads because my clinic and pediatric residency was at Boston Medical Center, and it's a wonderful model. Essentially, there's a prescription pad in every clinic room, and our electronic medical record at Boston Medical Center actually prompted us to screen for social determinants, so that was also a nice model. And when there were concerns that came up, whether it was around food or housing, even things like summer programs for kids. For a lot of my low-income patients, finding out about those types of resources is not necessarily easy. So there's a prescription pad, and you basically checked off what the issue was, gave it to the patient like a prescription, and they could access health leads whenever they wanted to. The computer, the desks were set up right at the elevator when you walk in. So they could go that day, they could come back at any point that was convenient, and sit down and work with the college volunteers. And the nice thing about this model at Boston Medical Center is that the college volunteers actually had access to the medical records, so they could leave a note saying, this patient came in, thank you for the referral, and they worked with us to address X, Y, or Z. So I think while this may be not, this may or may not be the right program for a school-based health clinic, depending the size and sort of the setting, certainly the idea of having, if there are local universities or sort of local students around, there could be sort of a model developed that's similar to this. Next, in terms of the professional category, is medical legal partnership. So this is an organization that places lawyers into the healthcare setting to benefit low-income and at-risk patients. It was also started at Boston Medical Center, both of these programs by Barry Zuckerman, who also started Reach Out and Read. So he's a very famous pediatrician with a lot of good ideas. And there are now over 95 medical legal partnership sites at over 250 healthcare institutions. I know in Boston there's one at Codman Academy and Codman Health Clinic, which is a joint health clinic and school, which is a pretty interesting model that many of you may know. And this is really based on the concept of preventive law, or sort of proactive legal assistance. And the idea is that, there's some problems that social workers can be very effective in addressing, but sometimes you just need a lawyer on the team to write that, strongly written letter to a landlord to address a housing issue, or, to address some other type of legal issue that a lot of patients struggle with. And so again, I was able to work with medical legal partnership in my clinic in Boston Medical Center, and when there was an issue that came up, we'd page them, we'd go over, they had their own triage process, and then they actually held clinic hours so we could refer our patients if they deemed that the case was actually a case they could help with. And when I first started residency, I was able to go to housing court with the lawyers who were actually representing the patients for free on issues around, landlords not doing their duty in terms of dealing with rodent infestation, other type of structural housing problems. So I think this is, an amazing model for primary care, and not even just primary care, but health care, particularly for patients that otherwise don't have access to legal resources. So I don't know how many sites combine schools and health. Some of you may know for medical legal partnership, but this is a great model just to be aware of. So what does all this mean for school-based health centers? So I think, school-based health centers are ideal for addressing social determinants of health. I think that, there's obviously an intersection between the adolescent's education and health in one setting. As Tiara started the call, schools are where adolescents spend the majority of their time, and so it's a natural place to really sort of dig into what else is going on in the adolescents' lives. I think school-based health providers, teachers, guidance counselors, the whole team have so much more of a window into the actual social context of what the kid is actually existing in. I know for us in the clinics outside of school-based health centers, sometimes you get an idea because kids will bring their friends or boyfriends or girlfriends to them into clinic, or the families come in, you get some idea of the dynamics, but it's definitely a different lens into what these kids are living with every day than I think people in schools have. And I think school-based health center providers, not only healthcare providers, but even teachers and guidance counselors could be trained to screen. So that's definitely one angle. But if nothing else, I think giving some training around the recognition that these problems can really drive stress and can actually affect healthcare outcomes, educational outcomes, and sort of the importance to be on the lookout. I know that teachers and guidance counselors are already aware of some of these issues, especially having kids in class saying they're hungry and sort of, having some window into the family situation. But I think people may not recognize the number of things to consider and really how those impact, directly impact health and wellness. And then schools could develop resource and referral guides or provide on-site resources. Interestingly, I'm doing work with the Greater Boston Food Bank in Boston and had done this project with them looking at where else they can sort of reach patients and students around Massachusetts. And interestingly, some of the high schools around the state are developing food banks on site because they've realized that once they start asking kids around being food insecure, it's definitely prevalent, and there's been a need, and so they're actually developing these resources on site at the school. So, that may not be possible at every school, obviously given, budget and sort of the right setting, but I think certainly schools should be the natural link between, helping families and students to connect to the other sort of resources out there that they need to be able to, have success, both educationally, social success, sort of be sort of overall well. And then finally, I think another important thing, especially for the adolescent age range, is I think with more training around the impact of determinants on health, it's also really important to also help adolescents realize the link between some of their symptoms and stress. So I have had patients come in and we figure out that there's obviously you want to make sure there's nothing scary going on with headaches or belly aches. Make sure you do your physical exam and history well. But I think it can help kids feel empowered to sort of start to realize that underlying stress really does drive physical symptoms. That happens to everybody. It may manifest different ways for different people, but that is a well-known link. And I think if they can recognize some of the causes for why they may be having physical symptoms, it also opens up more of a door to really talk about what else is going on. So what would social determinants of health screening potentially mean for our patients? So one example, but having been trained in social determinants of health, the nurse at the school-based health center recognizes the potential connection between Jenna's headaches and underlying stress due to social triggers. She screens her food insecurity, and Jenna screens positively. The nurse then walks through some of the other iHelp screening questions, and Jenna opens up more, disclosing fears around her family's income insecurity, worries about the risk of eviction, and increasing frustrations in school due to the fact that she's struggling from not getting the extra support she needs, and also her thoughts that she's been having about dropping out to help her family financially. She also does reassure the nurse that she's in a safe relationship and finds support from her boyfriend. The nurse lets the social worker at the school know about Jenna's home situation so they can be connected to resources. She helps Jenna to the right guidance counselor to initiate the IEP evaluation process. She talks to Jenna about the connection between stress and physical symptoms. So I think, again, one example of a case, but certainly I think opening up the door to having these conversations and at least helping to make the link to school-based health providers and other sort of team members in the school system, I think could definitely make an impact for adolescents across the country. So thank you again to the School-Based Health Alliance for inviting me to speak and for everybody for logging on to listen today. Given that all of you are the experts around delivering care in school-based settings, I'd love to hear your ideas for how to roll out this type of social determinants education and training to school clinicians and team members. And thank you again.
Thank you so much, Dr. Baer. We'd definitely like to give everyone an opportunity right now. If you have any questions, please enter your questions in the question box. And while we're giving others the opportunity to enter their questions, we do want to take a moment to mention the School-Based Health Alliance membership. And while at the School-Based Health Alliance, we work to improve the health status of children and youth by advancing and advocating for school-based health care. Our members extend and support our work. Trainings like this webinar would not be possible without the support of our members. In addition, our members receive exclusive access to valuable programs, timely publication, and networking opportunities. We would like for all of you, if you can take a moment after the presentation to please visit our website at spaceforall.org/membership for more information and join us. So Dr. Baer, I think we do have a couple of questions that have come in. Our first question is, which screening tool do you find most useful?
So that's a great question. I think for me, the iHelp screen is most useful. Again, there's always the reality of having only a certain amount of time in clinic, and so I admit, I do not get to all of those questions in a clinic visit. Although I think the food insecurity screen again I like it because for me it sort of opens the door to asking more questions, and I tend to find more things coming up as being positive. I think certainly depending on the kid in front of you, they may or may not be aware of other issues going on. So I think one is that you should never assume kids don't know, especially I find that kids where the parents may not speak English as a first language, oftentimes they may be the ones who are actually taking their parents to fill out the right forms to get on different different resources or sort of help. And then but other kids, depending on their developmental stage and family situation, may actually not know anything. So food insecurity screening I definitely do, and when there's time or with other concerns that come up, I go into more of the iHelp questions.
Great, thank you so much. Our next question is, Is the social determinants of health screening data automatically loaded into a patient's EMR?
That's a great question. So it would depend on the EMR. There's so many different models out there. At Boston Medical Center, they're pretty advanced with their previous EMR, and so they had those questions embedded. I've never seen that anywhere else. And in my current clinic, I either type the note myself or I dictate into the chart. So it's only up to me to make sure that it gets in there. I think if there was a way to develop this into the medical record so it becomes just a standard part of what's being asked, that would be fantastic. But it all depends on the record system and the willingness of people to put those questions in.
Okay, thank you so much. How do you handle HIPAA issues with health leads using college students, volunteers with minors? Can you refer to a resource that has this information?
Yeah, that's a great question. I would refer you directly to the Health Leads organization to ask that question because I don't know the answer. I'm not sure whether the volunteers, it may have been that they only had access to a limited portion of the chart when they were there, and so I think they had the capability of writing like a brief note to say patient came in and accessed this. I don't believe they had access to any other part of the medical record. But again, there are a number of different models, and so I would ask Health Leads directly.
Okay, thank you. We see a couple of ones that are trying to come in. We'll just give one more minute. Can you talk about how you arrange partnerships for referrals, like to a food assistance program?
How you would arrange partnerships for referrals?
Yes, that's the question.
Yeah, I think that's a great question. I mean, certainly, so with my work with the Greater Boston Food Bank, they're a huge food bank. They distribute food through 500 member agencies, so it's definitely a much more massive food bank model than I think potentially exists in other states or local communities. But I know they are always looking to be a partner to schools, and they have a number of models, whether it's a backpack program or a mobile market on the school site. So I think it's probably just reaching out directly to to these sort of local community resources to see what type of partnerships could be developed. I think the other point about food security screening, and actually any of the screening, is I'd first ask, are the patients getting access to either the state-based or national resources they should be? So for food security screening, I think the SNAP program, or the Supplemental Nutrition Assistance Program, formerly called food stamps, patients it is a very underutilized program, and there are a number of families who qualify that actually are not getting those benefits and should be. It's certainly, I mean, there's been studies to show that the benefit does not actually provide sort of the full amount of food that a family would need, but if they're not getting it, certainly it can be a big help. So in terms of thinking about connecting to resources, I would first start to say, like, what is actually available to you based on income levels and other qualifications? Make sure that they're connected to programs like SNAP, and then also think, how do we also supplement that with community resources that are out there? So it would depend on the community, but I think direct outreach to see what these organizations are capable of would be the first step.
All right, thank you, Dr. Baer. Have you seen or used the Prepare, the written assessment tools from NIAC? Any pros and cons in the SBHC setting?
Just repeat the tools. I'm sorry. What's the name of the tool?
It's Prapare, Prepare.
No, I'm not familiar with those tools. If someone wants to send me, let me know about them and send me some information. I'd love to see it. I'm not aware of them though.
Okay. Is there any maybe like templates that we can send anyone to assist them with this screening? Is anything that you recommend? Any resources?
Any resources for screening?
Yeah, any templates that they can use, yeah.
So that's a good question. I don't, to be honest, so my clinic doesn't even do this the way that we probably should in terms of having this templated and nicely screened. I know that one person who's done a lot of this around actual clinic screening is Arvind Garg. His last name G-A-R-G, and he has published a number of studies around a program called We Care, where they've done this much more abbreviated screen for social determinants and on paper, so it's much more simple, not electronic. So certainly, whoever's asking, I could help connect them with Arvind. I could also reach out and get his example of a template, and I'm happy to send anyone the iHelp screen, just so people have it and can adapt it for their own use. While the language on that slide is, as much as possible, we use the language that has actually been validated in research studies. Again, with these being teenagers, I think it's always, you always want to make sure that teenagers actually get the question you're asking. So certainly, while almost nothing's been validated. So I would say even just adapting these questions to use on your own and making it in the language you think the teens would understand is a much better first step than doing nothing. So I'm happy to send out slides to anyone who wants to see them and help connect people to others who are have used these more in like a research setting and have more data around success.
Okay, thank you so much. Another question we have, do you suggest only doing food screening during well-child visits or on a more frequent basis?
Oh,
okay, I'm sorry.
Oh, go ahead, I'm sorry. No, finish your question, sorry.
I just had a kind of a next question to follow up to that. If you do discover social determinants, follow-up be scheduled?
Sorry, if you do discover social determinants, what?
Follow-up be scheduled?
Yeah, so good question. So I would recommend food insecurity screening more frequently than the regular visit. So, and again, it doesn't necessarily have to be something you ask about every time, although, I would say, for food insecurity in particular, national data shows that it does ebb and flow. So certainly there are families that are always hungry or always food insecure throughout the year, but in reality, a lot of times it's situational. So, a family may be, getting by with either not utilizing resources like SNAP or, other community resources, like they're doing fine on their own, but someone could lose a job and that can totally change things. Or, new family members could move into the home. Or in Boston, with a high cost of housing and the cold in the winter, they've done studies at Boston Medical Center to show that people make a decision in the wintertime between the heating costs and cost for food. So I think, just because someone says, no, we're not food insecure in their summer physical exam does not mean that in the middle of winter that they might have that same question. And especially for patients who, live under the federal poverty level or, sort of more underserved, like there can be many frequent changes in their lives that could change their sort of overall situation. So I would definitely recommend screening more. And for me, I think it particularly comes in when kids come in with symptoms that are, where the physical exam doesn't know what they're saying or complaining of. So the chronic headaches, the chronic belly pain. Some of those, I think, it's good to start thinking a little bit outside the box before jumping to prescribe the medicine that may or may not help, depending what's actually going on. the next question was, oh, to have them follow up. I mean, absolutely. I think, you know, if you think about what, our responsibility as providers is to really think about health more holistically, and especially for kids, kids are mostly healthy beings compared to adults. So a lot of what I find myself doing in clinic is sort of, preventive screening, counseling, making sure that, things are going okay in school, things are going okay at home, because I know that those things actually can really impact their health a lot more than their chance of getting cancer, some of the other things that adults have a much higher rate of, or risk of getting. So, I think definitely if there's a social risk that comes up that seems very prominent, we do schedule close follow-up. I think one, to emphasize to patients or students that it's okay to talk to your doctors about this. And actually, there's nothing to be ashamed of. There is this link between what's going on at home and your ultimate health outcomes. So that's fine to talk about. It's great for you to recognize that early. I think the other thing is that, I think like the patient we talked about in this case, when things start to compound on each other, that's when kids can sort of go down a slippery slope. So it would make me really worried, even if the headaches went away in this case and I saw her in clinic and she seemed to be doing fine there, I'd still want to follow up to say, how are things going at home financially? Like, are you still thinking about dropping out of high school? Are you, how are things going with your younger siblings? Because, some of these things ultimately could have this patient make a decision that would much more impact her ultimate health over the long course of her life, as we know from the statistics, than sort of not following up. And that being said, I don't, depending what types of providers are in your healthcare setting, it doesn't necessarily have to be the physician who follows up. It could be a social worker or a resource specialist like we have in my clinic. But in reality, if there isn't that support, I would still really encourage providers to bring the kids back in, even if it's a brief check, to say, just how are things going? Is there anything that we can do to be helpful?
Great, thank you so much. We do have a final question before we conclude. Let me see. All right, can you share examples of where social determinants of health were used prospectively to a subpopulation as risk stratification?
So that's a good question. So I think one example is for LGBT or questioning youth populations. We know from the literature that they have a much higher risk of being having risk of housing problems. There's much higher rates of being disconnected to their family. From people not accepting their sexual orientation or just having big fallout. So I think definitely there are certain populations that I would say, on top of just the normal teenage risk, are particularly risky. And I would say that's definitely one population that I would especially screen for, because there's a higher chance of those kids having problems with housing, income, and higher rates of mental health concerns too, and suicide risk.
Okay, great. Thank you so much, Dr. Baer. We're going to now ask our attendees just a few poll questions. And if you want to still submit your questions, you can. And those that we're not able to get to, we definitely will make sure that we respond to you via email. We see a few of you have also sent additional email information. We do appreciate it. We would first like to ask you, did this presentation meet your needs? If you could just please take a few seconds to answer the questions. Great. Thank you so much, everyone. Our next question is, how likely are you to apply information from this presentation in your organization? If you can please take a few seconds. Great, thank you everyone. How well did the presentation meet the stated objectives? Thank you. Our final question is, would you recommend this webinar to others? Please take a few seconds. We also want to remind everyone that this webinar is being recorded. The webinar recording and the slides will be uploaded into our website in 3 to 5 business days. We will send you an email with that information. All right, thank you everyone for attending today's webinar, and a serious thank you to Dr. Baer. We really appreciate this. Was an amazing webinar, and I think you answered quite a few questions this afternoon. Is there anything else you would like to add before we conclude?
No, thank you so much for having me, and if anyone wants to be in touch over email, I'd love to hear your ideas. I don't actually work in a school-based health center. I don't know if I didn't make that clear up front, but certainly have seen the model used, have it's rotated through as a resident, and very much believe in it. So would love to hear whether what I was talking about resonates with you in your school settings.
Great. Again, thank you so much. We will definitely be in touch, and would like to thank again all of our attendees, and we hope everyone has a wonderful day.